Good afternoon, everybody. My name is Marwan Abouzoud, Director of the Transplant Institute. I want to welcome everyone to our lecture series. I was reminded to make sure that everyone remembers to silence their pagers and their cell phones, since we are going to be televising and recording this program. So today it's my pleasure to introduce Dr. Lloyd Ratner, who is the Surgical Director of Kidney Pancreas Transplantation at Columbia University in New York. Dr. Ratner is a good friend and a colleague both in transplantation and also in affairs of the American Society of Transplant Surgeons. Dr. Ratner has completed his medical education at Hahnemann and subsequently did general surgery at Long Island Jewish. Subsequently going to WashU for the transplant surgery training during the early years with Dr. Wayne Fly. And this is a program that I had looked at actually at the time as well. And he went back to Baltimore, or went to Baltimore to Hopkins to start in kidney transplantation and multi-organ transplantation. But one of the things and unique opportunities he had was the ability to innovate. And this is where he started the process of looking into living donor nephrectomies. And he was the first in the world to start this procedure. And this started him on a journey of innovation, not just in living donor transplantation, but per kidney exchange and protocols for desensitization that we are all aware of at Hopkins. After a very good tenure at Hopkins, he moved on to Columbia as Surgical Director of Kidney Pancreas Transplant, where he's been there for the last 15 years and grown a very successful program, part of a great enterprise led by Dr. Jean Aymon. In addition to his interest in innovation and laparoscopic procedures, Dr. Ratner also acquired a significant interest in access to care and a variety of approaches of how to improve access to care, and this will be the subject of his presentation today. He has many honors and many recognitions, and I mentioned some of them in the announcement, and he has served on many boards regionally, locally, as well as nationally, served on UNOS board, and also a significant tenure with the American Society of Transplant Surgeons, where he served as secretary and on council, and currently, as of this June, as president of the American Society of Transplant Surgeons. So it's my pleasure to introduce to you Dr. Ratner, a friend and a speaker.
Thank you, Marwan. It's really my pleasure to be here this afternoon. So I think this afternoon we'll talk a little bit about access to transplantation. There are my disclosures. My financial disclosures are minimal. Basically, I work for Columbia University. They pay me. My wife spends the money. It's basically a direct pass-through. And as you can see, my fiduciary responsibilities as well. What I'm going to talk about this afternoon is all my own opinion and is not the opinion of any of these organizations per se. This is where I practice. It's Columbia University Medical Center. It's a big place in a big city, lots of patients, lots of sick people, lots of really good people working at the institution. So my goal this afternoon is to be provocative. And let me just take you back to a moment in 1993 when I was pretty early out of my fellowship, and I had a young woman. She was 28 years old. She was highly sensitized. She had been on the deceased donor waiting list for about 6 years for a kidney transplant at the time when the waiting times were about 2 years. And we got a kidney which was a one-antigen mismatch for her that she had a negative cross-match with. But the donor was a 77-year-old. And I thought that this would be a bad idea. I thought it would be a suboptimal kidney and that she wouldn't really benefit from it. So I discussed all the options with the patient, and I recommended that she shouldn't undergo the transplant. And she said something that really resonated with me and really changed my whole approach to my academic career. Prior to that time, my interests had been in like cell biology and immunology. But she said, I've been on dialysis for 6 years of what should have been the best years of my life, but they are the worst. I'll never be able to live with myself if I don't take this chance. And I looked around, I said, okay, if you want to go for this, we'll go for it. And I said, well, you're going to get a suboptimal kidney. I wonder if anyone is using the other kidney. And no one was because of the age of the donor. And that was actually the first dual renal transplant utilizing suboptimal kidneys to try and increase the organ pool and increase access to transplantation. And it's sort of that seminal moment sort of changed the focus of my academic career to focus on access to transplantation. Well, so it started with the use of these expanded criteria donor kidneys to dual kidney transplants. Then I got interested in the removal of live donation, of the disincentives to live donation, which resulted in the development of the laparoscopic donor nephrectomy. And then we started using desensitization for a positive cross-match as we saw more and more people come forward who had donors but were immunologically incompatible. And then we started doing ABO-incompatible transplants, which led us to start doing kidney-paired donation. Then we utilized the use of compatible donor and recipient pairs. And with that, I've gotten more interested in the issues of process and organization in terms of access to transplantation. So although it may seem like a disparate areas, in my mind, they all fit very nicely together because they're all about access to transplantation. So what I'm going to talk about this afternoon, I'll give a little bit of background data on the waiting list, transplants, and deaths, and then we're going to lay out a structure of how to look at the issues of access to transplantation and what I call friction points in the donation to transplant process, and how policy and organizational structure impact on these friction points. Then I'll talk a little bit about organ procurement organization functionality, transplant functionality. I'll float some ideas about some policy that we could use which would improve access to transplantation. And then finally, I'll just spend a couple of minutes on living donation. And so access to transplantation is probably the most significant problem facing the field of transplantation today. It really has the greatest impact on patient survival, whether someone gets transplanted or not, and it has profound impacts on all other aspects of care, what type of organs we're going to use, how aggressive we're going to be, what the risks are, etc. It's only partially driven by an inadequate organ supply, as I hope you'll see this afternoon. And things like xenotransplantation or growing organs from stem cells or building organs on scaffolding and all that, those are solutions that are likely decades away. And the lack of access, I would contend, is multifactorial due to misguided policies, inadequate organization and management, and lack of science in important disciplines. So this is data from my own institution. These are people on the kidney transplant waiting list who either got transplanted or remained waitlisted, and you could see over time the profound difference in patient survival. Well, this is nothing new, but this is just to demonstrate again that whether you get transplanted or not really has the biggest impact on whether someone's going to survive. Now, anyone who's been in transplant for more than 20 minutes has seen this slide ad nauseum with the growing number of people on the waiting list, with the number of transplants growing, but to a much less degree than the waiting list. So there's this huge disparity. And particularly with kidney transplants, although I will talk in general terms, most of the examples I'll give will be in kidney transplantation for two reasons. Number one, that's my area of specialty. And number two, it's the largest number of patients. But the number of kidney transplants has remained relatively static until the last few years, which has been mainly affected by the opioid crisis. And what's happened is, if the number of people waiting goes up and the number of transplant remains static, then the transplant rate, by definition, is going down. So people have less chance of getting transplanted now than they did back in 1993 when I told you about that seminal case. And what's happened is the waiting times have increased significantly. So if you think about the organ supply and demand, we start out with a whole lot of potential, both living and deceased donors, and we start out with a whole bunch of people who could potentially get transplanted and would benefit from a transplant, but we only transplant a relatively small number of the potential supply and the potential demand. And what we really want to do is we want to have the supply and the demand be equal and meet the demand of the patients. So if you think about these schematic terms, let's look about the factors that impact on the organ demand first. So there are those patients that could benefit from a transplant. And then we have a number of different steps or friction points where we lose patients. So patients that have the financial resources for transplantation, okay? No one's going to transplant you if you can't pay. And in some places like Texas, only 17% of the population don't have any medical insurance. Then you get those patients that get referred to a transplant center, which is a smaller fraction of those that have the financial resources. Then those that actually get evaluated, and then finally those that finally get put on the waiting list. And each step of the process, we've lost patients who could potentially benefit from transplantation. Now, if we look on the supply side, you have a large potential supply of both living and deceased donors. Obviously, this is influenced by societal attitudes. Some people are very willing to donate, other societies less so. And I'll show you some data, transnational data about this a little later. Then there's a legal framework. You can't just go taking organs from people, right? They have to sign, there has to be consent. And there's a legal framework for doing that. Then, particularly with deceased donors, you get down to the hospital functionality. So, all deceased donors come from a hospital somewhere, and how well that hospital functions in identifying donors, timely referral to the organ procurement and organization, et cetera, has an impact. Then, how the organ procurement organizations function is a big issue. And as been said, if you've seen one organ procurement organization, you've seen one organ procurement organization. They're all very heterogeneous and function differently. So each step of the way, we're losing potential organs. Then there's the science of organ function optimization. So optimizing the donor management, getting the organs to work as well as possible so we could get as many patients transplanted from an individual donor. And for a whole variety of reasons, there's been almost nothing done in this field. And then we lose organs based on our allocation scheme, which is imperfect. And then we lose organs at the transplant center level in terms of their functionality and aggressiveness. Then we lose some organs based on patient issues, and then finally we lose organs based on outcomes, which I'll talk a little bit more about later. So each step of the way, we're looking at losing a couple of percent here, a couple of percent there, a couple of percent there. So, those people who say, well, there are big fixes, presumed consent, or paying donors or paying donor families, I think those are all pipe dreams, and because they're not looking at where all the problems are. And I think what we need to do is have multiple solutions addressing each of these things each of these levels. And as you'll see, each of these things are impacted by various different factors: demographics, education, culture, management, logistics, whether or not there's incentives, psychology, et cetera, et cetera. So, to fix this problem of organ supply and demand and access to transplantation, there's going to need to be a number of different solutions acting at a number of different levels. So, let's look at some of our problems. So, we have policies that are often at cross purposes. So we want to expand the donor criteria and utilize suboptimal organs, but we penalize transplant centers for having suboptimal outcomes. There's administrative boundaries without relation to biology or patient behavior in terms of organ allocation and functional units of organ recovery. There's no single organization or group that's looking at the big picture. The dialogue has been extremely limited heretofore, and there are a lot of policy, legal, and financial barriers to the scientific study to improve organ function and availability, and there are huge organizational and operational differences at the OPO and transplant center levels. And I'll spend most of my time talking about some of these issues. If we look at a map of the United States, the death rates vary quite a bit. So I practice here in New York. We have a very low death rate. It's about 660 per 100,000 patients. Okay, if you go to a place like Mississippi, it's 950 per 100,000 individuals. And you can see it's quite a bit of disparity across the country in terms of death rates. And I'll tell you that in New York, people tend to die older, and they tend to die of cardiovascular disease, whereas in the South, people tend to die younger and of trauma and things like that more commonly. So the potential organ donor pool is very different in these different parts of the country. Now, in terms of hospital functionality, again, the deceased donor availability starts at the hospital level. There are approximately 5,000 hospitals in the United States, of which about 250 are transplant centers. That means 95% of the hospitals in the United States that we depend on for organ donors really derive no benefit from organ donation. They have no skin in the game, and the Fed, CMS, who really regulates them and provides funding for them, really puts minimal requirements on them to have any skin in the game. The Spanish model is that organ donation is part of the mission of every hospital, and they have organ donation coordinators at every hospital in the country. So it's a very different system than our OPO-based system. So that's one place to start. Well, we have 58 federally designated organ procurement organizations. Each OPO serves a donor service area. These donor service areas are defined by arbitrary administrative boundaries, which were made back in the 1980s. They're very heterogeneous in size, population base, and number of transplant centers. They all function very differently. And the donor service area, in large part, determines allocation. And in fact, there's a fight going on now whether or not to pull allocation out of the donor service area and make it much broader, regional or nationally based, to the point where it's even gone to court and got tied up in court. And so the last word on this is not out yet. Well, from 2007 to 2011, we saw a large increase in the number of deceased donors and the number of deceased donor transplants. But if you look at the 15 largest OPOs, some of them did very well. They increased their they increased the deceased donor rates by 15% or more. But yet other OPOs, including my own here in New York, that actually had a decline in organ donor rates. So how these organ procurement organization function is also very heterogeneous. Now, what about at the transplant center level? So, what are the incentives and disincentives to organ acceptance? How could these incentives and disincentives be altered? Has our scientific training and approach been deleterious to transplant? And are we asking the right questions and interpreting the data correctly? And then what's the psychology behind accepting organs for transplantation? So when I was at Johns Hopkins, I started the desensitization program there. And I left there, and that program continued and, in fact, grew quite a bit. And they wound up getting flagged by CMS and UNOS for having suboptimal outcomes because they were doing so many desensitization patients. And Dr. Samaniego was there and lived through all of this. And you could see in this paper published by Bob Montgomery that in the New England Journal that if you compared the patients that got desensitized and got transplanted, they actually had a much better patient survival than if they either remained on the waiting list and got a deceased donor transplant or stayed on the waiting list and remained on dialysis. So even though this modality of therapy was doing better for the patients than the natural history of the disease, the transplant center was punished for doing this. Okay, there's something wrong with a system that does that. Similarly, this is a paper published by Jesse Schold. He looked at mortality on dialysis, those patients listed, and he compared them to centers that either performed consistently better than expected, those that performed as expected, or those that performed worse than expected consistently. And you can see, although there's about a 5% difference at 7, 8 years, 6, 7 years, it's still dramatically better than if they hadn't been transplanted. So, those patients, these centers got into trouble for having suboptimal outcomes relative to the other centers. Now, we live in a punitive system, and the caption reads, okay, I admit it, we're lost, but the important thing is to remain focused on whose fault it is. And that's the world we live in. So what Schold also showed was that those centers that got flagged for suboptimal outcomes, their volumes decreased. Okay? So that's the worst thing for the patients, is to lower the number of patients and decrease access to transplantation because they didn't do quite as good as the centers that did better than them. Okay? There's something misaligned here. Now, so what are the determinants of organ acceptance? I would postulate that ideal donor organs are accepted readily, but maybe not. The opportunities for growth are at the margins, and that marginal donor organs are turned down for a variety of reasons, what I call rationalized turndowns, and I equate it to when you go to buy residential real estate. So you go look at a house. It's inhabited, it's inhabitable, someone is living there. And you go, the closets are too small, or maybe the yard, I don't like the yard, it's kind of sloped, or, and you could make a rationalization for turning it down. Well, no deceased donor organ is optimal. I mean, they all have something wrong with them. They're coming from dead people, okay? We have our existing prejudices. So the question is, can rationalized turndowns be minimized? And what additional factors influence organ acceptance and turndowns? So this is our residential real estate analogy. It's got a lovely view of the beach. I don't know, I wouldn't buy that house. I like the beach, but. So Yogi Berra, who was the Hall of Fame catcher for the New York Yankees, he was famous for his saying things that were kind of funny but made sense. And he once said, when they were talking about in the 1950s, when television was becoming popularized, and there were declining attendance at baseball games, he said, if people don't want to come out to the ballpark, how are you going to stop them? And my corollary is, if people don't want to transplant organs, how are you going to stop them? So now, let's look at the impact of our performance metrics. So what's happened is our current performance metrics are basically 1 and 3 year patient graft survival. So what's happened is that the outcomes have gotten better with our performance metrics for a variety of other reasons as well, but you could make the argument that the performance metrics had a role in that. And the heterogeneity of outcomes between transplant centers has also gotten tighter. So you see, you have a much tighter bell-shaped curve in terms of performance, center-level performance. Okay, that's all good. But if you look at the probability of getting a kidney transplant, there's huge regional differences. So these are the 11 different UNOS regions. And the vertical bars are the track at the different center levels. So you can see there's, from one region to the next, there's big difference in the probability of getting a kidney transplant in terms of access to transplantation, and it varies quite a bit at the center level also, even within regions. One of our nephrologists, Sumit Mohan, published this paper, which looked at kidney offers prior to death on the waiting list. And it turns out that, on average, patients have been offered 24 kidneys before they wound up dying on the waiting list. Okay? And the amount of time that elapsed between the first author and them eventually dying is about a little bit less than 2 years. So, the question is, why is that? Why are people turning down organs that could be utilized for transplantation for specific patients? Well, one of the things that we've seen is that the kidney discard rate has increased over time, and it's increased since the introduction of the new kidney allocation system, or CAS, in December of 2014. And now the discard rate is it's about 23, 24% of all kidneys procured. This is Sumit Mohan, and we've also shown in work that he's done that the discard rate of kidneys varies by day of the week, and that the highest discard rate is on Fridays, and kidneys that are procured on Friday and Saturday, because they're likely to be transplanted on Saturday or Sunday, okay? And it's not that those kidneys procured on Fridays and Saturdays are worse kidneys from worse donors. If you adjust by KDPI, they're being discarded at lower KDPIs on the Friday and Saturday on the weekend kidneys, and we call that the weekend effect. And again, you could see there's tremendous geographic variability in terms of kidney discards. Interestingly, those areas that have the higher death rates have lower waiting times, mainly the South, have higher rates of discards. So there's something wrong with our allocation system. If they don't want to use those organs, get them to other people quickly who will be able to utilize them. Well, you say, well, maybe it's just those high KDPI, those suboptimal kidneys that are being discarded. Well, that's true. There's a lot of suboptimal kidneys being discarded. But when you look at the lower KDPIs, they account less than 85%. They account for 50% of the kidneys that are being discarded. Okay? And you can see there's significant overlap in terms of quality of the kidney, quality of the donor based on KDRI versus those that are transplanted. We all know from this data, this is Ojo's data, published in 2001, holds true today, that there's a significant survival advantage relative to dialysis if you utilize suboptimal kidneys. Not as good as the survival advantage of using optimal kidneys, but survival advantage, considerable survival advantage nonetheless. Well, these are the variables that go into KDPI, but one of the things that's happening, because it's a percentile ranking, it's very difficult to sell these higher KDPI organs to patients. So you say, Mrs. Jones, I have a wonderful kidney for you. She goes, oh, that's great, doctor. How wonderful is it? How is it compared to another kidney I may get? Well, Mrs. Jones, 95% of the other kidneys are better, but this one's good for you. You can see the dilemma that we face in being able to sell these organs to the patients. They frequently don't want them. And what's happening now is, since the KDPI is recalculated every year based on the previous year's transplants, what's happening now is the whole thing is being shifted to the left. So what used to be a 90% KDPI, or what used to be an 86% KDPI, may now be the new 90% KDPI. So as we discard more and more of those higher KDPI organs, we're getting down to this part of the curve, and there's really trivial differences in outcomes between many of these organs that are being discarded. Frequently, people are turning down organs based on biopsy findings, and this is a paper that hasn't been published yet, but it's by our group at Columbia, where it looked at biopsies that were done in outside OPOs. They were all brought back to our center, imported to our OPO, and they had 2 core biopsies, 14-gauge core biopsies, read by dedicated renal pathologists who read them all the time for the OPO. And it turns out that the outside OPOs, if they were suboptimal versus optimal biopsies, they had no difference in outcomes, whereas the biopsies that were processed as cores and as read by dedicated pathologists, they actually were able to better predict how those kidneys will function and what the graft survival is. So the problem is that although people are making decisions on these biopsies, these usually being done as wedge biopsies, which are less predictive, they're being read by pathologists of varied skill and experience on frozen sections, which are very different to read. And this is a study that hopefully will be coming out soon. It's just being submitted now. Now, you're sitting there and going, I do liver. These kidney guys, they're throwing away all kinds of crap. And, why are they, we don't have to worry about that in liver. Well, the fact is, this is a paper published by Dusty Carpenter, who's one of our residents. He's going to be our fellow next year, where he looked at the variation in liver utilization, not only by day of the week, but by time of the day. And he looked at not only discards, but also donors, actual deceased donors, that the liver was also not procured. So, and what he showed was that the discard rate, or the non-use rate, the non-procurement and discard rate, is higher on the weekends, as would be expected from our previous kidney study, but he also shows when it's influenced by time of the day, and those organs that are cross-clamped, those donors that are cross-clamped at night have a higher non-use rate for livers than those that the procurement takes place during the day, okay? Which makes an argument for regional procurement centers where you have control over the operating room time, where it could be optimized to meet the needs of the transplant teams and the patients themselves. And there was also considerable variation by region, as you could see, the 9 UNOS regions. your region 10. These are your discard of liver rates. Weekend versus blue. Orange is weekend versus weekday. I read this book called The Mathematician Shiva. It's kind of a funny book, but one of the quotes from the book is, "Smart people do stupid things far more often than most people realize." And so let's talk about the PHS increased risk. On your left, you have, this was Eliot Spitzer. He was the governor of New York until he got involved in a sex scandal, and they found out that he was sleeping with prostitutes. He had been a prosecutor before becoming governor and prosecuted prostitutes. While he was governor, he was sleeping with them, and he had to step down. But all other accounts, he would have been sort of an ideal organ donor. You have Tiger Woods here, who, you know, if Tiger Woods before his sex scandal had been hit in the head with a golf ball, you know, and then they went to his wife and said, "Oh, you know, does Tiger Woods, you know, sleep around?" His wife would have said, "No, of course not. He's Tiger Woods. You know, he has a beautiful wife and it's everything he wants." And, you know, then we find out he's involved in a sex scandal. Both of these guys would have been considered PHS increased risk donors, right? So we recently had Sridhar Basavaraju from the CDC come and speak at Columbia. And these next three slides are going to show you I've gotten from him. So most of the growth in organ donation has come in terms of deceased organ donors, has come from the increased risk, or the PHS increased risk donors, mainly from the opioid crisis. And there are some localities now where 25% or more of the organ donors are considered increased risk. And their utilization, both for kidney and liver, again, broken down by region, and then by individual centers in terms of the width of the box plots, indicates the proportion of the increased risk donors that different centers utilize. So a center's philosophy about whether or not they want to accept increased risk donors will impact people's access to transplantation at those centers. How they kind of think about the risk, and I thought this was really interesting when he talked, is they're saying, okay, at what point, because they're thinking about redoing this. So many people have complained about the increased risk. They said, okay, we'll take a look at it. And they said, okay, at what point can we say that the risk of catching HIV, and they've done this for HIV, hepatitis B, hepatitis C, these same kind of plots, at what point does that risk get to be less than 1 in a million? Okay? So if you have a negative NAT, what's that window period where you get to be less than 1 million, 1 in a million? So it's about, for men having sex with men, it's about 11 days. For HIV infection, men having sex with men who inject drugs, it's again about 11 days. But so where did they come arbitrarily with a chance of 1 in a million? I mean, a chance of 1 in a million, that's so small. That's less than the chance, way less than the chance of dying from being a living kidney donor, which is about 1 in 3,000. So, why not 1 in 10,000 would be at 0 days, the window period. So anyway, there's a lot of interpretation that goes on here that is subject to question. So the implications of all this is that we need to question existing practices and prejudice. In some of these cases, particularly in terms of what organs we're going to accept and, staffing on weekends, may require management solutions rather than scientific ones in terms of how call schedules are arranged, who accepts the organ offer. You know, if you're the one who has to get your ass out of bed in the middle of a Saturday night, at 3 in the morning on a Saturday night, you may have a different take on what organs to accept than someone who doesn't have to get out of bed to do the transplant. We've shown that there's misalignment between incentives and goals. And I think we also need to generate original data for process improvement rather than necessarily for academic publication. And hopefully we'll get a Hawthorne effect. Now, this comes to the question of how do we change our policies? And I make a few policy recommendations. First, I think if you look at policies are to try to encourage or discourage certain types of human behavior, okay? So our first policy characteristic should be that as a clearly stated goal. There should be consensus about what that goal is. There should be pilot preliminary effectiveness data to show that the policy actually does what you hope it will do. There ought to be realistically implementable and executable. What kind of resources does it require? We don't want to spend, to get a minimal impact on outcomes, we don't want to put a lot of resources into that. We want to have objective measures of success or failure for the policy. We ought to be collecting data on whether the policy is effective or not. And there ought to be a timeline for analysis of effectiveness of the policy. And we ought to be able to identify unintended consequences. And there ought to be mechanisms to adjust the policies accordingly. And basically in our system, we don't have any of these things, by and large. Now, I would contend that our transplant policies goals are we should encourage access to listing and transplantation. We should encourage utilization of organs by decreasing discards and encouraging live donation. We should be able to have policies that allow us to address the vexing problems facing patients, that we ought to be able to encourage innovation. We should be able to maintain excellent outcomes. We don't want to lose ground, but there also ought to be value in what we're doing. So those are ways how I think about how policy ought to be changing. Now, fortunately, in the ASTS, we have a voice in, at least the organization as a whole has a voice. So I'm the current president of the ASTS. Dr. Abeljoud will be president next year after me. So, we potentially have a big say in some of these issues. Now, so some ideas to overcome some of these problems. The first is what I call dealing from the bottom of the deck. And that is short waiting times mitigates the suboptimal outcomes that we could get with utilizing suboptimal organs. So now, this is difficult with current allocation. So instead of taking these suboptimal organs, offering them to people who have been waiting on the list for years and years, who could the next week get a good kidney or a good liver or whatever, offer them to the people that just got on the list who will say, okay, I'm willing to cut off 5 years of waiting time and take a chance on a little bit worse organ. Okay? What happens now is by the time these get to people who could potentially really benefit from them, they have long cold ischemic times, and that's problematic. And obviously, recipient selection is critical. The recipient has to be able to withstand a suboptimal outcome. So the patients that just got on the list generally are less sick and have a better reserve and will probably do better if they have a suboptimal outcome. Now, people will argue that, well, the people who have waited the most should get the first crack at any organ. That's the equitable aspect of equity, of organ allocation. And I would counter that without utility, there is no equity. So if these organs are being discarded because they're not getting to the right person early enough in the allocation process, equity is moot. Then the other idea I would float is what I call the wild card solution. So what I would say is to encourage listing of patients okay, I would say that a percentage of patients that you list would receive wildcard designation. You could make that percentage 3%, 5%, 10%, whatever you want. And these wildcard patients are excluded from the overall performance metrics. The catch is you have to designate these patients prospectively before they get transplanted. But what that could do is it would encourage the transplant of patients with risks that aren't included in the risk adjustment. It would also encourage centers to cohort patients with difficult problems, because that's really the only way you're going to get a handle on some of these difficult problems if you see enough of these patients. But if you have a difficult patient with a hard problem that's not included in the risk adjustment, why would you take on a lot of those patients to try and make things better? You're only putting your program at risk if you do that. So, and then this would encourage innovation and experimentation. And the wild card you could use for whatever you want as long as you declare it prospectively, so you don't say, oh, I got a bad outcome, this is a wild card patient. And if you want to use it to cohort patients with antiphospholipid antibody syndrome, who are difficult patients to take care of, or if you want to use it to transplant the 83-year-old mother of the CEO of the hospital, that's your prerogative. You could use it any way you want as long as you declare it prospectively, and they're not counted in your outcomes metrics. Okay? So that's another idea. And then finally, I would say that our performance metrics should assess the entire continuum of care with an intent to treat analysis. Okay, from evaluation to listing to pre-transplant. So basically say, how many people are alive at the end of the day, rather than 1 in 3 year graft survival and patient survival, where you cherry pick patients. Now this could also lead to cherry picking, but I'm pretty confident that there are ways, if you start with referrals and look at population bases, that there ought to be some equitable way and fair way to do this, to make an intent to treat analysis as our metrics. Well, as Yogi Berra said, in theory, there is no difference between theory and practice, but in practice there is. So, this will take a lot of work and time, but I think this is where we need to be moving. So, in the last couple of minutes, I just want to focus on living donation. So, living donor transplantation, are there better ways to do things? So, I told you I would show you some transnational differences, and you could see that there's huge disparities in terms of both the utilization of living donors by country and also that of deceased donors. And in general, those countries that have good deceased donor rates have poorer living donor rates, and vice versa. So why can't we be optimizing both? This is an old slide. It's from 2013. The names will be different, but the outcome's pretty much the same. So I looked at the 15 largest transplant centers in the United States in terms of kidney transplant and the percent of live donor kidney transplant. And you could see it varies from quite a bit from UC Davis, about 15% live donor transplants, to Methodist Specialty Hospital in San Antonio, where about 2/3 of their transplants are living donors. And we were down here in the middle at 50%. But living donor kidney transplantation is only about 35% of all kidney transplants nationwide. And living donor liver transplant is just beginning to have a resurgence in the United States. And what are probably about 350 living donor liver transplants done per year out of about 7,500 liver transplants. So it's a real minority. So the basic question is, have we maximized living organ donation? I would say no. How do we identify potential organ donors? Generally, we rely upon the recipient. How do we educate potential organ donors? Well, that's the transplant center's responsibility. And have we optimally utilized all the resources at our disposal to increase living donation? And I would say no to that as well. Now, we have what we call a community-based approach that's utilizing different community resources to try and find and educate organ donors. So you have people out there who are willing to donate, but the recipient may not know all individuals that are willing to donate. The people that are willing to donate may not know of a recipient, so the potential donor may not know all the individuals that are in need. And potential donors are more likely to donate to someone that they share something in common with, this feeling of commonality. And that's where the community-based approach, I think, could be a much better approach to identifying and educating living organ donors. So, other advantages of a community-based approach, well, it has infrastructure in terms of publications, meeting places, websites. They have third-party individuals that could act as recipient advocates in terms of clergy or organizational leaders, and the ask could be depersonalized. And, so I often say that, asking someone to donate an organ is almost like trying to sell life insurance, right? How many people here think they could be an effective life insurance salesperson? Okay, which is probably why you're not doing it, right? So why do we ask people who may not have any skills in order to be able to ask people to donate an organ to go out and speak to their relatives and loved ones to do it? Okay? And also, the interpersonal relations can be minimized. So someone who beat up their brother for, their whole childhood now, and who's, and the brother's wife hates him, now he's going to ask the brother to donate an organ. That may not be optimal in order to be able to get the organ, the brother to donate. So there's an organization in New York called Renal. This is the guy who founded it. It's a grassroots effort in the Orthodox Jewish community. His name is Mendy Ratner. He wanted to donate a kidney to a friend, and he got ruled out for medical reasons. And he said, okay, if I can't donate my kidney to you, I will find a donor for you. And so he started this organization. These are some other members. This is what I call my Where's Waldo picture. Obviously, that's me in the middle. But so what they did, they built this organization that helps educate the donors and the recipients and their family members, looks for family members to donate, helps them navigate the healthcare system, provides transportation, childcare, et cetera, et cetera. And to date, they've been in existence for 13 years. They've facilitated over 600 kidney transplants, of which more than half have been from non-directed donors, primarily from the Orthodox Jewish community in New York, in the New York metropolitan area. And those non-directed donors account for somewhere between a quarter and a third of all non-directed donors in the United States. So a small community-based grassroots organization is utilizing these principles of a community-based organization to get donors has had a profound impact and is really a model for what could be done in other communities, be they religious communities, unions, alumni organizations, whatever, however you want to define a community. So, in summary, I'd say that access to transplantation is the single most important factor in transplantation success. Access to transplantation is driven largely by the organ supply, but really is a complex problem. There are a large number of friction points where organ supply is diminished. It's going to require multiple solutions acting at a diverse group of obstacles to overcome this problem. We need to utilize all the resources at our disposal, and some of these solutions will be controversial and may be ethically challenging. We need people who are willing to push the envelope and challenge convention, and there are lots of opportunities for improvement, and there are multiple models where things are done well and where they are done poorly that we could look at for guidance. So, once again, I'd like to thank Dr. Abeljude for inviting me. I'd like to thank you for your attention this afternoon, and I'd be happy to entertain any questions. Millie.
As always, Lloyd, it was fantastic. There was a point you mentioned and had to be with the education of physicians that are supposed to be referring these dialysis patients for transplantation. I think at the society level in nephrology, we are really not doing a very good job. Most of the nephrologists go into private practice now. They go into dialysis. Yet there continues to be a high variability, and there is a conflict of interest. Perhaps the PPW may have some impact. Is there any way that the ASTS, the AST, can do an outreach to the National Kidney Foundation, to the ASN, to try to make this better?
Yeah, I think that there certainly is that possibility. And certainly, I think, there are disincentives to referring people to transplant. The nephrologists and the dialysis units make a lot of money on dialysis patients. And, even if they're well-intentioned, it's just easier to just, do what you do every day. And so I think we need to make it, easier, and there need to be financial rewards for referring people to transplantation. So one of the things that we're going to be doing in the ASTS is we haven't really had a strategic look at our advocacy efforts. So we want to look at our advocacy efforts and say, what are our top priorities? Where do we want to put our resources? Where do we want to spend our time? And something like this may very well be one of them, but I think that, that's some of the things that we need to be doing. There's limited resources in the societies, but I think, my experience has been the NKF, at least, is a receptive audience, and they need some guidance because they are largely driven by by lay people. The ASN, that's a tougher nut to crack because, there are 30,000 nephrologists in the ASN, and the vast majority of them are affiliated with dialysis units. So, Darla.
Last week they had a listening session at the White House, and they invited the OPOs, and they invited the nephrologists, and they invited the AST, and I'm assuming they didn't invite you because nobody from the ASTS was there.
Well, they didn't invite us per se, but our lobbyist was there, and our new executive director was there, but he just started like the week before, so he doesn't know enough to be effective in that situation yet.
So then the people from Organize got into an argument with the people from the OPO, and so really nothing was accomplished. And so then now this week, they're going to come out with what the new incentive payment structure is for dialysis. And, nobody really knows what it's going to come down to. I mean, already, HRSA has already told the dialysis units that referrals are one of the metrics to transplant centers and one of the metrics that they're being measured on. So that's already happening. That's new. I mean, we may not be seeing some of it. I mean, we are seeing some of it where we're seeing, like the 85-year-olds getting sent to us.
Right, like there are referrals and there are referrals, right? So, yeah.
I mean, I have to say that being in Michigan, we're in an easier position than people are down south, where at least with Medicaid expansion, we are financially able to transplant people that our colleagues down south may not be able to. When you have to go to Emory or Piedmont and pay, you have to have $2,000, cash up front before they'll even talk to you. I mean, obviously none of our patients would have that ability here. I mean, there are moves that direction, but as long
Right, you need a more objective metric than they currently have.
Yeah, but it's, you know, it's just, it seems like all of these things are getting worse rather than better. The only thing I took that was encouraging from that meeting last week was that they are looking at incentives for preemptive transplantation, which is really the time to get them before they start making money for the nephrologists.
Right.
Also incentives to the OPOs, is there any process so that they can not only harvest the organs in a responsible manner, place them, improve the health of the organ, and place that organ? Is there any incentive there that would help increase the number of organs placed?
No, there really isn't a lot of incentives to the OPO. But these are the kind of questions we need to be asking, and we need, like I said, we need to define what our goals are. As long as the goals and the outcomes have been the 1 in 3 year patient graft survival, you know, you're not going to get any of this other stuff. You have to be able to say, okay, how do we get the most people to benefit from transplant, and what does it take at all levels from start to finish? So.
This is more of a comment. Following your advice about the community outreach, Gift of Life here has tried to, it's actually a current campaign targeting African Americans, Muslims, and Hispanic, young people in particular, because we think that trying to get this young group of college students, high school students, is probably the way to go. Nevertheless, the OPO doesn't really understand that they can use all those resources that you mentioned in order to bring patients from the community. A good example for Hispanics, the associate bishop in the city of Detroit is from Mexico, speaks perfect Spanish, but no one had approached the Catholic Church, which is so crucial for Hispanic patients in particular. There has been also a big problem with Muslims, with Muslims only making about 5 donors over the 5 period to the OPO here, when we have the largest, one of the largest Middle Eastern communities in the United States. All of this to say that the OPO they need to be educated as well. Talk more, although we are all part of this, talk about these things with the transplant centers where they can get guidance as to how to do this outreach to them.
Yeah, no, I think those are all good points. I think, you know, I think one of the things that made Renewal so successful was because it was really a grassroots effort that really understood that particular community and what their needs were and all. So, I mean, so the difficult thing is, how do you encourage grassroots efforts like this, you know, to take on this model that's been so successful? Obviously, every community is going to require little tweaks here and there, but, you know, the fact that you have the infrastructure, you have the individuals, you have the meeting places, you have the websites, you have a cultural awareness. So, you know, like in New York, we have about over 130 different languages spoken. You know, how do our half a dozen transplant coordinators work on educating every population without, you know, without having the cultural sensitivity about organ donation and all? It's difficult. So I think what we should be encouraging are those type of grassroots efforts.
But that's what San Antonio did so well. As you point out, they have the highest living donor ratings in the country, and because, to be blunt, they didn't have a lot of transplant centers that were, you know, whatever. They just went out in the community, and in San Antonio in general, they went through the city and got people to know.
Yeah.
Yeah, but that's also a more homogeneous population in Texas.
Yeah.